Well, good morning, everyone, and thank you so much for coming to join us today to explore Zoom in healthcare. My name is George Lillig. I run our healthcare division here at Zoom. I also lead our government and education teams, some crossover in those businesses once in a while, and we just really appreciate you coming. We have a really distinguished panel to help lead our discussion today. These folks have a diverse background. They come at the subject of healthcare from 3 different places, so we thought that'd be a really interesting conversation for us to explore. So I kind of, to set the stage, I thought I would just draw out a couple of parallels. So if you think about it, this journey to provide collaboration in healthcare as a journey or a continuum, on one end you have Zoom, who's this as you listened this morning, is this really great, easy to use, simple, collaborative product. And on the other hand, you have an encounter that could be between a couple of clinicians or a patient and a provider, and what's in between. So there's this notion that I think is really interesting called liminal space, if you've ever heard that. And that's the idea of the threshold. So if you're going from one room to the next and you're crossing over the threshold, you're in that kind of scary space of what's over here now, and what am I leaving? And it's been shown that liminal space is where some of the most interesting and creative things have been developed, in that kind of like, where are we going? And so I thought that was a pretty interesting analogy, kind of crossing the threshold to get from here to over here. I'm gonna call our panelists artists. You kind of take a nice piece of marble on one side, and somehow an artist turns it into this really cool statue, and our panelists here have done that. So to introduce our artists, I'm going to have them kind of introduce themselves, and just to warm us up a little, I thought I'd have them tell us when they were a child what they thought they might like to do when they grew up. So first, Joshua Scales, would you introduce yourself, please?
My name is Joshua Scales. I'm the HIT manager at the Tennessee Primary Care Association. We're a membership organization that provides support to all of the FQHCs throughout the whole state of Tennessee. And I actually lead our telehealth program there, where we utilize Zoom to provide the video connection. When I was a kid, I wanted to be president.
Nice. Still time.
Until I realized and started to notice all of the things that presidents go through. So I kind of changed my mind after that. But realistically, I just wanted to be great. That's it, whatever I chose to do.
Nice. Thank you. Welcome. Thanks for joining us.
All right.
I'm Linda Branagan. I'm the director of telehealth at Ucsf, just up in San Francisco. My mother was a nurse, so when I was a child, I wanted to be a nurse. And I'm really glad that there are many more career opportunities for women available now, because now that I work in healthcare, I understand just how hard it is to be a nurse. I'm really glad I've had options.
Oh, that's great. I'm Bill Szaroletta. Thanks to everyone for coming. I'm the Innovation and Technology Officer at Project Echo. I am on a couple of boards. That one is the New Mexico Telehealth Alliance. The other one is the New Mexico Health Information Collaborative, which manages the Health Information Exchange. And I'm a professor in the Innovation Academy at University of New Mexico. When I was a kid, I got in so much trouble for taking things apart and trying to make them better. So I always wanted to solve problems. And I think I've aligned in the career path. I solve problems.
Great. Thank you all. So I'm going to tee up some questions for us. We'll probably run about 20, 25 minutes with that. We'll go a little deeper dive so you can get an understanding of what they've gone through to try to build these programs. And then we have 15, 20 minutes available to do some Q&A. So why don't we go a little deeper, Joshua, in Tennessee. Mm-hmm. Maybe you can help us understand, use cases. How'd you get started? ROI? What's the receptivity that you see?
Well, the program that we run, we have over 8 different specialists available on our network to all of our FQHCs, to where we use Zoom to provide the connection to those rural health centers in very rural parts of Tennessee, to where, let's say the closest specialist may be 45 minutes to an hour and a half away. So some of our health centers have difficulty recruiting and retaining certain physicians, especially the specialist physicians. So we kind of provide that middle that middle layer to where their patients still have access to those specialists, but it's just via telehealth. Right. We also deploy all of the telehealth carts and technology in the health centers too, and we use Zoom to do that transmission. The ROI for us is just seeing the amount of encounters that we do on an annual basis, right, which lets us know that we're providing access to those patients, you know. So last year we did over 3,500 encounters in 12 months, and that's with 8 different specialties across our network. We've negotiated rates with local specialists to where they've kind of carved out certain times that they're willing to see our patients, and our health centers staff, they know the times, and they work with the specialists and their referral coordinators to, you know, schedule times to where they can see those patients virtually. So we're not in it for any financial reasons, you know. The main reason is to expand access and to ensure that those rural health centers and the FQHCs in the state of Tennessee, the patients have access to care.
Great. What led to the inception of the program? How did you get from what we consider a traditional provider, you know, story to trying to serve people this way?
Well, the program started back in 2014, and it consisted of more layers of very tech-driven program to where there was a data warehouse and this whole shebang came along with it. Well, that grant ended, and they wanted to keep the telehealth side going. Okay. So we just kept growing the telehealth program and working with the health centers to keep those different specialists on board. And, and it just grew out of nowhere. You know, I've been at the Primary Care Association for going on 8 months. Prior to that, I was director of telehealth for a company called LifePoint Health. So seeing the things to where it started in 2014 and to where it is now, the word telehealth is now very popular, right? Yeah. It's actually being accepted as a modality now in the industry. So I'm actually seeing a lot more uptake in it. I have a lot of specialists calling me saying, hey, we heard you have a telehealth program. How do we connect with you guys? You know, we would like to see some of those patients. So I think that is going to continue to grow. Working with different third-party vendors to kind of add on to the program that we have to expand it more. Looking at different specialties that we currently don't have, you know. So excellent. I think that it's going to continue to grow, and I'm excited for what the future may hold. Great,
thanks, Josh. And Linda, so you came at it from the university standpoint, significant university here in the Bay Area, kind of known around the world.
Yeah, well-known academic medical center. Our biggest video-based program is just video visits with patients in their homes. UCSF is home to a great number of medical specialists, some of them who are extremely unique in their fields. And about 70 times a day, we do a video visit with a patient who does not have to drive to San Francisco and try to park there. I just recently did the math. We've actually saved, the number of driving miles that we've saved our patients is equivalent to 11 trips to the moon.
Wow.
We're very fortunate in California in that there is a telehealth parity law, so private payers are required to pay for to reimburse for telehealth if the equivalent in-person service is also covered, and that reimbursement is at the same rate. So the financial challenges that many of my peers in other states face regarding this kind of home-based video visit just really doesn't happen for us, for which we're extremely grateful. Every patient, after they do a video visit, gets the standard Press-Ganey CG-CAPS experience survey. It's the same one they get in the ambulatory environment with a few small changes, right? We take away questions that don't make any sense in a video environment, like did the staff wear gloves, right? And we add a couple questions about the video visit. And we find that pretty much across the board, patients rate their provider more highly. They feel like the provider understands their condition better. They understand what their provider says more clearly. And the comments are just incredible when they choose to leave comments, you know, the amount of money they save, the amount of the stress of travel. Like, traveling is stressful for sick people. And then the way it doesn't affect their family as much as if you don't have to pull kids out of school for a big trip to the doctor and that kind of thing. So that's really been amazing to see.
Was this, Linda, sort of a natural evolution for the university health system to do this, or did you kind of step off of a
We
cliff?
sort of stepped off a cliff in late 2014 when they created my role. Suddenly there was a telehealth programs office, and we kind of went at it. We just went at it, right, head on. The parity law is a huge incentive if you don't have to keep convincing people that really you can get, you know, that there is a way to get paid for this. Like, as soon as we had data suggesting that the parity law was doing its job, it got a lot easier. We have not had any significant resistance. We have about 500 physicians who are enrolled to participate, and any given month, about half of them do at least one video visit. And it's spread throughout. It's throughout the institution. It isn't just in a clinic or two. Our basic method is my office will help you as much as you need help. So we will help you. Sometimes we just give people instructions and they go with it, and sometimes we visit over and over again to make sure everybody's comfortable and clear. We sit with them for their first visits.
Nice.
Whatever they need, we give them, and that pretty much works.
Nice, thank you. And Bill, so your program is a little different than Josh and Linda's in what you're looking to achieve. And so why don't you tell us about how this...
Project ECHO's guiding principle is to move knowledge, not patients. And to do that, we have specialists that are at a structure we call a hub. And these specialists meet with practitioners out in rural and medically underserved areas with weekly virtual clinics. And we call those tele-echo clinics. And they share knowledge, the expert to the practitioner, through a learning loop. And then, like medical school, the practitioners will present cases. And then the experts at the hub will provide guidance. But through the learning loop, the other folks that are around the spoke network can also chime in and provide guidance. Our goal is by the year 2025 to touch 1 billion lives in a positive way. And to do that, we have to use scaling and leverage. Our partnership with Zoom has enabled us to do that. In 2003, when Project ECHO was formed, we had one hub that was focused on one disease state, and that was hepatitis C virus. Our founder had an 8-month wait time, and that was so long that patients were coming to him or not coming to them because they had died, or they were past the point where he could treat them. And he said there has to be a better way. And through that, he came up with this idea to just travel around the state of New Mexico and find people that wanted to learn how to treat hepatitis C virus. I mean, it was tough. It was chemotherapy-like treatments, and nobody was going to touch it. But through the ECHO network, he got his wait time at the academic medical center down to 2 weeks. 2 weeks. He's seeing the sickest of the sick, but the triage is going on out in the rural areas. There was a New England Journal of Medicine paper that was written on this that showed that the treatment of those patients, the results of those patients that were out in the culturally appropriate setting with people they knew, that they didn't have to travel to the moon and back, many times to come to the health center, was better than what it was at the health center, and that changed a ton of things. So with that, I'll just...
Your program's become very large. Maybe you give the group a sense of just what your
Okay,
worldwide
I said we
footprint is.
started in 2003 with one hub, one disease state. I joined ECHO in 2012, and it was really an inflection point at that point. We had added our first international partner just prior to me joining. So we had 2 countries in 2012. So that took 9 years, 2 countries. And we had 21 partners at that time, that people at University of Washington, University of Chicago and Illinois, Utah, and were early adopters of the same program because they said, that works, we're going to try it at our institution. Today we have 32 countries, and we have 235 partners. So we went from 21 to 235, roughly in order of magnitude growth, but the country growth has gone up 16x, and we absolutely could not have done it without Zoom.
Great, thanks, Bill.
You're welcome.
Yeah.
He paid me to say that, but he didn't, actually.
There's a common theme here of scarce resources, and how do you get the most out of a scarce resource? Each of you talked about there's certain providers that you have, and they're so valuable to these people. And one thing about the cloud and the way we can deliver this now, we can provide this access so much easier than we used to do it back in the day of the industry. So it seems to be a common thread. There must be some best practices that you learned in crossing the threshold here. What would come to mind, Josh?
When you're dealing with specialists that you've negotiated rates with and you're dealing with small individual clinics, sometimes the processes and policies associated with the transition of care of the patient can get cloudy. So that's one of the main things. You have to make sure that your policies and your processes are in place. Because if I'm a specialist and I've taken time out of my schedule to see your patients, and there's a very high no-show rate in which that virtual visit is taking place of an actual in-person visit that could happen if they weren't seeing your patient. So just make sure that your policies and procedure are in place and everyone understands what needs to be done and how to follow the transition of care of the particular patients. Because that's just one thing that I've seen in the past is that the provider is telling me, well, we had 10 patients not show up last month. That's money that I could be, So just trying to keep everyone happy. If you just make sure your policies and procedures are in stone and everyone understands what to do, be fine.
So building process.
Building processes.
Because you said originally it wasn't necessarily all about money, but it can become complicated and then it can become a cost problem. Right?
Very much so. Yeah, because a lot of our FQHCs, they see undershared and underinsured patients. Right.
Yeah.
So those self-pay rates that we've negotiated with the payer, with the actual providers, those patients are paying out of pocket in some instances. In some instances, we have grants to cover the underinsured and uninsured patients, but it still can get a little cloudy between the actual specialist and the health center.
Sure.
So just making sure those policies are in stone is the best way to go.
Good.
Yeah.
Thanks. And Linda, so in UCSF's crossing this
I think our
chasm.
most used best policy is relentless optimism. Because we really are asking physicians to change the way they do some of their work. And for some people, that is fine. They are happy, they are ready. Sometimes they have more questions. They're a little afraid of how this will be different, how they'll be perceived differently. And respect for that state is really valuable. Just like I understand that, let's do what we need to do to make sure that you're comfortable with this is really important. And just patience and just assistance, right? We're here for you. We're absolutely willing. We're here with you to make this work for you in whatever form that takes. But you got to be optimistic the whole time.
Power of positive thinking.
Exactly.
And Bill, how about in your case in your journey?
What a journey. We had been with a room system company since the beginning, 2003 to 2012. I've got a couple of colleagues here. I've got Anne Mary McLeod. I've got Frank Roybal. And Frank was on my interview committee, so he's a direct witness to this. During my interview, of all things, I said, we go away from an appliance-based solution because there's no way we're going to be able to scale worldwide and touch 1 billion lives. With an appliance, I'll need a group of 1,000 support engineers. I said, we have to go to the cloud. And I still got hired, which is amazing. So, so that was hurdle one, is going from one paradigm of this works really well, these appliances, once you get them installed. The problem was it took 6, 12, 18 months to raise the money, to get things installed, to get the equipment bought, to get all the things that are required to do the training and the operationalizing of the system. And we had to do something that was completely different. So we evaluated a ton of about 24 options, and we ended up choosing, we selected 2 as finalists. And there was a reason that we chose Zoom. As I teach my engineering students, you always look at performance to price ratio. And Zoom was very, very good. But it was, we just heard Stephen Covey Jr. with the speed of trust, Eric Yuan, Nick Chong. We had Greg Holmes and Daniel Branagan were the 4 people that Frank and I primarily negotiated with. And we had a tremendous amount of trust in Zoom when they were just a tiny little company. And they had trust in Project Echo when we were just a tiny little organization in the internal medicine group at University of New Mexico. And once we made that decision, the director was like, Zoom who?
So there was some faith involved in that liminal space.
Yeah.
Well, it took a lot to get him on board, to get everybody else on board. But once we started rolling it out, July 1st, 2013, everybody just goes, it just works. And at that point, there's a lot of stories on that we'll save for later, but about the initial surprise and the initial success around that theme of it just works. But it took trust up at the front end to get Zoom from a very well-established room system company that George knows well.
So in your case, the technology itself was kind of a liberator to what you could accomplish.
Absolutely.
Yeah, I've been in telehealth for a long time, and I swear for the first 10 years, all we did was try to get the video to work.
Yeah. Put a cap
And
on
that
things.
problem is literally gone.
Yeah.
We don't have that problem anymore. Now we're not out of problems.
Right.
But, that's not one we chase.
Speaking of problems, so I'm sure there were both internal and external challenges or resistance, or I'm sure the audience encounters this kind of thing. What would you say that you experienced that you kind of had to deal with, and maybe still deal with?
I mean, gaining buy-in from those physician champions is number one, right? You have to gain buy-in from the physicians and the support staff to actually have a lucrative telehealth program. I mean, a telehealth program can be quite expensive, depending on which level of care you're providing. But gaining buy-in from the right stakeholders is the number one thing you have to do in order to push it forward, right? I like Zoom because it's very cost-effective and it's simple. I think the key in healthcare to make something work and to make people happy is simplicity.
Is
right?
that part of the house? So how do you get that buy-in? You prove the simplicity, or?
Yeah, you have to prove the simplicity. If it works, it works.
Yeah.
And with physicians, the more clicks, the EHR world, the whole high-tech Meaningful Use Act has physicians very angry about the different processes that come along with maintaining their EHR and their workflows, right?
Yeah.
So as I do introduce new technologies, new ideas to our FQHC CEOs and some of the physicians, I make sure it's simple. And I make sure it's very end-user friendly, which Zoom is that.
Yeah.
That's why I like it.
Excellent. And how about at UCSF?
Honestly, at this point, one of our biggest challenges is the clash of the ease with which providers can do video visits and state licensing laws. Because they have to see patients only who are physically located in states where they're licensed, which for the vast majority of our providers is only in California.
Yeah.
And they'll be like, so what if the patients move to Nevada? Like, actually, the Nevada Medical Board cares about that. So it's just a clash in ways that, states don't have laws written around this to really support this or acknowledge this. It's going to be interesting.
Does the university, work on behalf of trying to push these things?
We are,
or?
Yep. We work closely with the Center for Telehealth and E-Law, which is an organization we're big fans of, to try to sort this out, and with the American Telemedicine Association as well, to try to sort this out, and the Federation of State Medical Boards. But it's a problem that's only going to get worse.
Yeah. Wow. Yeah. And Bill, how about in your case? What kind of things did you encounter that you had to solve for?
Well, one of our biggest problems, and this is one that it's the trust of the Zoom team, is people had spent hundreds of thousands, in some cases millions of dollars, on their room systems. There was this huge infrastructure out there.
So they felt invested.
Our job at Echo was to respect that and move forward with a solution that would both do the modern technology, the H.264, the H.265, and moving forward, which a lot of Zoom is on, but also to develop a connector to the room systems, the H.323, the H.239, to actually put that in place. And Eric Yuan looked at me and he said, and he looked at Frank, because we were at this meeting, and he said, we'll do it. And it was a Zoom meeting. And he said, give me to April. And he showed us an early prototype in April, and they went worldwide in May with that. And that was a differentiator, because now we could roll this thing out, and we really didn't care whether people used our new system or not. They could have their own system, but the economics of this new paradigm were such that they just deprecated their old systems and started going into the Zoom systems. And now we've got the new wave with Zoom rooms that we're going to be really pursuing.
It is our mission to really, in this vertical space too, to have you define us. I talked about the space between here and here. We're really focused on being super sharp here with collaboration. That's a big challenge in itself. So we really look for our customers to define us. Bill, we consider him one of our founding father customers, because some of that advice he gave us early on has really evolved the company. So thank you for that. I thought I'd ask him about unintended consequences. I asked this question once to a group of educators in Alaska, who up there, there's a real need for combining kids, because they're very remote, into classrooms, and they have a really wonderful program going on up there. And two of the kids said to me, well, one of the unintended consequences was he asked me to the prom, and he's 200 miles from here. and I'm like, did you go? And yeah, we went. So I thought that was a pretty neat unintended consequence.
That's fabulous.
How about in your world? Did things arise that you didn't really expect, good or bad, or just unusual?
The etiquette that comes along with the visit. Yeah. And because there's a lot of provider-to-provider telehealth that we're doing. We're not really into the direct-to-consumer space yet in Tennessee. But it's just the etiquette for the patient and the things that take place during the visits.
Patients in a rural clinic.
Yeah. Because the patients come into the rural clinic, and they have the virtual visit with the provider at the distant site, right? So in some instances, the nurses would leave the room, and the patients would do things, and the doctor would say, man, he did X, Y, and Z. We couldn't control, we can't control what a patient does, but it's just communicating clearly with the patient so they can understand exactly what the etiquette is during the virtual visit. And ensuring that the staff and the support staff and the nurses understand how to articulate that to the patient.
Interesting.
Which is the key. So a lot of times you're how you articulate things, you may have to dumb it down a tad bit so a patient can understand. Right? Because in a lot of rural areas, this whole telehealth visit thing is new.
So there's a little like an anxiety maybe just getting involved.
They know FaceTime, right? It's like, it's like a FaceTime visit? It's like, it's similar. Except it's a doctor on the other end. Right? So just ensuring that you communicate that effectively across the board is...
I've had telemental health people tell me that in some cases, the screen in the middle, actually with children, makes for a better experience, because the child feels more safe.
Right.
And of course, they're used to communicating that way as well in a lot of cases. So
right. Okay. One interesting story is that we had spun up a telemental health provider. They wanted to use our network to do it, right? Well, one of the clinicians called me and said, well, Josh, this product works great, but I just had a patient that said the TV was talking to her. So, and then you take her in the room, and then you have this person on the other end talking to her, So they was like, that was kind of interesting.
A little advanced explaining, maybe.
That's exactly what it is.
Interesting.
But, check the notes.
Right, you got to check the notes to understand what's going on with the patient. But she shared that with me, and I thought that was hilarious.
Nice. How about in your case, Linda?
I have two. So UCSF has 3 main campuses in San Francisco with clinics sort of sprinkled all around. And we've had cases where a patient has arrived for what should be an in-person appointment at the wrong clinic. And rather than throw the schedule off at the clinic they're supposed to be at the entire day, the clinic they arrived at just sat them down for a video visit. Right? Nice. So schedule saved. Good. And then the other one is about 1.5 years ago, there was a new drug to treat progressive multiple sclerosis, and really the first drug-based treatment for that disease to become available. And UCSF has a significant multiple sclerosis clinic. And literally every patient heard about this drug and wanted an appointment with their doctor as soon as possible. And so the MS physicians came to us and they were like, could we do like a webinar or something where we just like told it, because the drug education portion of the visit, that's what the visit really is. And it's a non-trivial drug. You don't just take a pill. It's a big, complicated regimen. Could we just do a webinar where we do the drug education piece of it, and then follow that up with like 5 or 10 minute in-person, like one-on-one video visits with each patient. And I was like, yes, yes, you can do that.
One to
You know,
many.
exactly, one to many, and then one-on-one. And it was the kind of thing where if they hadn't already had experience with Zoom and the ease of use, if they didn't already feel facile with it, they never would have thought, oh, let's use this in a slightly different way.
Wow.
Right.
Yeah, interesting.
Yeah.
How about you, Bill? Anything rise up that you just really didn't expect?
Oh,
That,
gosh. As an engineer, it's hard to be surprised, but Zoom has given us so many surprises. When we were piloting this, before we had rolled it out, I have a personal Zoom meeting ID, and it was 10:30 at night at Echo, and I was working on performance evaluations, and just that time is indelibly etched. All of a sudden, I had 2 screens, and my other screen popped up, and it was a doctor in India, the west part of India. He leans forward. He goes, Bill, you're so clear. I knew right then that we had a winner. 3 months later, he had called me up via Zoom, and he had said, we had 60 psychiatrists around India that typically would take 12, 24, 36 hours to get to an annual meeting, either in Delhi or somewhere where they would have that. They had a Zoom meeting with all of them. And it was the most incredible experience for them, that they didn't have to travel. They had all this other time to do the things that they needed to do. So that's a positive surprise. We had one group that was an international group that had a teleecho clinic, and they wanted to have off-hours meetings. Usually the teleecho clinics are an hour and a half or 2 hours. This one was 2 hours. Well, a typical week has 168 hours in it, and there's 2 hours of Zoom meeting. So we opened it up for them, but what we found out was that other people were using the other 166 hours of our Zoom meeting time. Once we found that out, and we had to deal with our information security officer and our chief privacy officer and our chief information officer to say, it's all right. We now have password protection. We now have the feature turned on where you can't join before the host has joined, and all was well. So that was kind of a negative surprise, but it also was turned into a positive in that our policies got strengthened through that.
Great, thank you. Last question for me, and then we'll turn it over to the audience for questions. If you had to think of an encounter that you know of that might help define your practice and what goes on in your world, is there a storyline that comes to mind?
I mean, with us, it's simple. The FQHC schedules an appointment with the distant provider. The patient comes into the office the day of the appointment, rooms the patient. There's a telehealth cart within the room. The actual screen comes on. The nurse introduces the patient, and they go through their spiel. And then the nurse leaves the room, and the visit starts. And then once the meeting is concluded, everything's shut off. The patient leaves. The notes are sent from the distant site provider to our FQHC, and that's it.
And that's your profile.
That's
nice.
it.
Yeah.
Thing,
How about in your case?
So with us, the patient gets the physician. Eligibility for telehealth is a clinical decision at UCSF. So if the physician decides the patient's next visit could be via telehealth, the clinic schedules a video visit, gives the patient information on how to set up their own equipment, either a phone or a tablet or a laptop. I think probably most of our patients use phones. Our providers use clinical desktops, usually their desktop machine with a camera installed, probably some laptops too. And the patient, when it's time, just clicks a link in their message, the patient portal sends a message, clicks that link, and then the provider admits them into the meeting room when it's time, and they just go.
Now, you told me, Linda, you have a patient that's
102. I think our oldest patient is 102 years old. Yeah.
And you asked them, you ever use an app before?
Yeah, that's sort of our screening question. Is like, do you know how to put an app on your phone? And if they're like, what? Then probably they're not going to be the greatest candidate for telehealth. But if they're like, totally, then probably it's going to work out fine. Our biggest, like the patients who are, or the family members who are the most appreciative of this are the parents of children who are traveling here. Because as soon as a kid is going to have a high intensity interaction with the healthcare system, I feel like an iPad is the family's first purchase, because you have a lot of waiting time and a lot of car time and all that stuff. So those parents are absolutely up on it and incredibly grateful to not have to be hauling their kid and their other kids in the car.
Anything that's chronic, I would assume, where there's return visits would be
Exactly.
really
Yeah.
situation
And our
like
providers
that.
love being able to see into the homes where these patients live, and
Yeah, right.
you know.
And Bill, how about storylines from your side? I mean, you have these
there's-
cultures
You know what?
coming from all over the world.
Yeah, we do. There's so many, but let me just focus one level above a story, and it's a story of Echo. As we are trying to positively impact 1 billion lives by the year 2025, we can't have a linear process. We need an exponential process. We have people that are in our prospect funnel that are kicking the tires, thinking about joining Echo. They come to our Echo introduction, our Echo orientation, Echo immersion, sometimes by Zoom, that they come in. Sometimes they physically travel. So what we are trying to do, we have negotiated a site license of Zoom for Echo purposes worldwide. Now that takes some negotiating. It's one of the most interesting deals I've ever negotiated, and it took trust on the Zoom team, because they said, well, what if you guys are like 1 billion users, like next, you'll swamp us. But we grew together, so it was a very, very strong partnership. So what we have done through this partnership is we've stripped off the technology layer. That's 6, 12, 18 months. And now, literally, we can do it instantly, and we can give people this technology, this tool to have their specialists communicate with rural and medically underserved areas in the medical space. But it's opened up tons of other spaces that we can move into with this same technology. So again, just to repeat, is Echo wouldn't be where we are right now with 235 international and domestic partners, and we wouldn't be poised to go to another order of magnitude growth on top of that without our partnership with Zoom.
Thank you all. It's really gratifying on our end to see that you guys are affecting people's lives this way. It makes us feel good when we get up in the morning, and it's because of what you've done with the tool. So thank you. How about questions from the crowd for our panelists here? Anything that would be useful to you, sir?
Jeremy Heiser with Health Insight. We're actually a hub
Hello.
for the Echo model, so I appreciate that. My question is kind of regarding telehealth. It's been around for 10 plus years, and in the scheme of technological advances has had really slow adaptation into the marketplace, and we're seeing changes as far as payers go and things like that. What are some of the challenges you're seeing in the future as far as educating clinicians or physicians to get on board, and also educating the public to get on board as you see adoption possibly growing? What are some of the challenges you're still experiencing in that growth of telehealth?
Everybody's looking at me. So the payer issue still absolutely remains in many, many states, far too many states. Patients, I think the FaceTime analogy that you made earlier is really, really true. I think when FaceTime came out, not just patients, but physicians also just suddenly got it. Yeah. They were like, wow, yes, right now I am talking to my kid on this device, but the quality of this interaction is such that it could totally be a patient, right? So we don't see tons of resistance the way we used to, because people are thinking less and less of this as a thing that might not work, right? I do think that it is important to make sure that eligibility for telehealth remains a clinical decision. Mm-hmm. We're seeing a lot of activity, especially around common urgent conditions, like is this cold really bronchitis, and is this just pink eye, like that kind of thing. We're seeing a lot of effort from payers to push patients toward video-based programs. But that's complicated. It's like patients don't want to see any doctor. They want to see their own doctor. They should see their own doctor. Continuity of care is a really important thing. So I feel like that's a place where we might struggle for a little while longer. But I feel like as long as patients feel that they're seeing a doctor via video when the doctor feels it's appropriate, and then the doctors know that that choice is theirs, we're in pretty good shape moving forward.
Hi, Dennis Vallone with Bayada Home Healthcare. Just curious if you're doing any sort of remote patient monitoring, deployment of biometric devices in the home in conjunction with the video.
We aren't. I am sure we will. I'm sure it's on the roadmap, one thing at a time.
Okay.
Yeah.
That's the next step for us too.
Yeah.
I think, coupling the virtual visits with the remote patient monitoring devices and ways you could connect with the iWatches. I think wearables are the next wave, right? Is to get actual data into a system on a patient and get it back to the providers and the care team so they can actively monitor those patients. I think that's the next wave, and that's something that I've been trying to negotiate with third-party vendors on, like trying to find a perfect product for us to pilot in particular markets within our FQHCs. But I really do think wearables is going to be the next wave.
Mm-hmm. Is this part of a move from healing to wellness?
Yeah, it's
Is
just
that
tracking
what you're seeing?
a patient's overall wellness in their activities and heart rate and weight fluctuations, et cetera,
Keeping them healthy.
And we need payer policies to follow that too. Because
Right.
nobody's getting paid to watch all of your data.
Okay, so speaking of policies, I have students in my Innovation Academy classes that are looking at this very deeply and coming up with product ideas that they can market and do things with. The big policy is privacy. Oh my gosh, to hook up and just put this data, who owns it, where is something that we have deep discussions about, because you got to know that that is your data. Now, how do you anonymize it so that you can put it into population health and do studies and analytics and stuff like that is a big, big deal. But the privacy policy for an Apple Watch, for a Fitbit, for any wearables, and fast forward 7 to 10 years and it'll all be implantables. Who's down for that? I don't see any hands. Okay. No, that's good. So privacy policy, I think, is huge.
Yeah.
Did any of your organizations give you any pushback during implementation around HIPAA compliance and maybe your information security office? Did you guys have any trouble in that area?
Trouble is an interesting word. We have policy and governance that everything follows or else, and we did not have any trouble with Zoom. Yeah, they signed a BAA, they passed our security review, it was fine.
Do you record?
We do not. It is against the terms and conditions of service for every medical encounter at Ucsf to record the provider. So that was already in place for the in-person environment, so it extends to the video environment as well.
Hi. Hello.
Are we
Randy
done
Graff
with
from-
HIPAA?
Pardon?
Were we done with HIPAA?
I'm sorry.
Did you get your question answered? Yeah.
You're never really done with HIPAA, are you?
No.
Are you compliant with HIPAA?
I'm Randy Graff from University of Florida Health. We're sort of relatively new in the Zoom market. We've been using another product for our telemedicine endeavors. My question for you is, we've been told by Zoom that there's different pricing for the telemedicine model. And I wanted to ask you, who are practitioners in using the product, what's the difference in the product itself? Are there any feature enhancements that aren't available with the regular client? Is there something different about the Zoom clients that you're using?
I can't answer that because the University of California as a whole negotiated our deal with Zoom. That's many, many, many levels above me, so I'm sorry.
Part of the answer is we do have a very specific pricing for education. It's targeted to the student. And so there becomes this blend, like in all these cases where you have a medical practice going on at the university, the pricing for the student wasn't intended for that market. We're kind of working with that, trying to figure out what the best thing to do is in that case, but that's part of the Zoom answer.
That's a great one.
Yeah.
So part of when we first rolled out Zoom at ECHO, there were a number of other organizations, other disciplines at University of New Mexico that would see our Zoom meetings. And Frank and I primarily, we'd go around and we'd do presentations. Daniel Branagan from Zoom would come in via Zoom and present Zoom, and they all wanted to go to Zoom. The Center for Telehealth, who, like I said, I'm on the board of directors of the New Mexico Telehealth Alliance. I worked really closely with Dale Elverson, who's a past president of the American Telemedicine Association. And he said, oh, we can't use Zoom. They don't have remote camera control. So I text Eric, come on, remote camera control. It was done. And all of a sudden, they went from, like I said, there was 2 companies that were finalists, and they had the other one. It started with a V and ended with O. You can figure that out. Anyways, they swapped, the Center for Telehealth at University of New Mexico swapped to Zoom. So
I can confirm that. I've done several Zoom meetings with Dale Alverson myself. So, yes.
I think we have time
convert.
for one last question.
Sure. Anthony Paoletti from Avidex Industries. How important is the camera? It sounds like a lot of these systems are on carts and they're wheeled into a room. How important is the camera there? Does it need to be pan-tilt zoom so you can, get someone in a wheelchair or a patient in a bed or someone standing? And how much, detail? Is it more just face-to-face meetings, or are specialists and physicians actually looking at conditions or things like that?
I think the camera is very important, but it just depends on the level of care you're providing, right? But there are different peripherals that you can get that Zoom can actually interface with, that the clinician can use to actually show certain areas on patients' bodies, or if it's a rash, if you're doing teledermatology, there's an otoscope that a Bluetooth-enabled otoscope that you can use that Zoom connects to. So I would say you don't have to get the best and biggest and baddest camera on the market. It all depends on what level of care you're trying to provide. But if you're doing behavioral health, you just need the face-to-face connection with the patient. Yeah.
So it depends on it depends on the use case, because we do inpatient telehealth as well. I just haven't spoken about it yet. We like a 12x zoom camera so that our provider can look at, really zoom in quite close on the patient's face, but also zoom out to talk to the whole care team if the patient's in a hospital in an ED, and also to look at equipment, right, equipment settings and those kinds of things. So, but if you're talking to your endocrinologist, from your home, and it's your 3rd visit this year, you don't need that kind of stuff, right? So just track the use case, listen to your doctors, listen to what they say they need.
So when we talk about cameras, we have to think, okay, cameras are taking, photons come in and they get transmitted, get digitized. Think about the future. I had an interview yesterday with NASDAQ, and one of the questions was, what do you see as the future? Well, digitizing you, but holographic images to transport, where you can have meetings, add haptics in there where you can have touch, and all of a sudden it adds a whole new dimension to telemedicine. It adds a whole new dimension certainly to telementoring, which is what Echo does, and that's going to be exciting as anything to see how that rolls out, with augmented reality and the machine learning, and how all those can just enable new things that none of us are even thinking about right now. So when you say camera, that's right now, but think what we'll be calling that device later.
So we run up against our time. Thank you all for your engagement. Please help me thank the panelists.